Hi, welcome everyone. We're going to give just a couple of minutes for everyone to join, and then we will get started. Hi, everybody. Welcome. My name is Martha Scarborough. I am the Regional Resource Director for Georgia and Arizona for Caron Treatment Centers. Thank you so much to everyone for joining us today on our webinar topic, using DBT skills and principles to address co-occurring mental health and substance use disorders. As a reminder, we will be conducting this session in webinar format, meaning all participant microphones will be muted. We won't be able to see or hear you, but during the presentation, please feel free to utilize the Q&A feature to ask any questions. And depending on the volume of questions, if we can't get to your question before the end of the hour, we will have someone from our team follow up with you directly. Additionally, the slides and recording of the webinar will be emailed to you within 14 days of the program to the email that you registered with. And today's presentation is eligible for 1 continuing education credit. We would like to thank our educational partner, CE Learning Systems, and also co-sponsorship with the American Psychological Association. Please note that in order to receive your credits, you will need to be on for the duration of the program and complete the post-webinar evaluation. A link will be emailed to you directly after the presentation from cego.com. After you finish the evaluation, you will have immediate access to your certificate of completion. Today, Caron Atlanta and Peachtree Comprehensive Health in Georgia are coming together for our webinar. After identifying our clients would see great benefits by utilizing the services we each offer, we established something called the Recovery Alliance. And this Recovery Alliance offers a 12-week intensive outpatient program, which includes a concurrent comprehensive substance use disorder treatment program paired with dialectical behavioral therapy for substance use disorder. This is also paired with a strong sober living environment or sober companion, such as Hope Recovery Resources and Recovery Frameworks. At the end of today's program, we'll list contact info for our programs if you want to learn more about this Recovery Alliance with Caron Atlanta and Peachtree Comprehensive Health. And today I am proud to introduce our presenters. We have Dr. Kim Vey and Kate Appleman. Dr. Vey is the president of the DBT Linehan Board of Certification and a DBT Linehan Board Certified Clinician. She specializes in treatment of mood, liability, anxiety, depression, non-suicidal self-injurious behaviors, and suicidal behaviors. Her goals in treatment are to help individuals learn healthy and adaptive coping strategies to effectively manage intense emotions and feelings and to build a life worth living. In addition to DBT training and certification, Dr. Vey has received intensive training in radically open DBT, prolonged exposure DBT for trauma, DBT PTSD, and a DBT protocol that has been adapted for children, as well as level 1 and 2 of TheraPlay and group TheraPlay. She also supervises other clinicians and provides DBT consultation to other DBT clinicians who are seeking certification or just want to enhance their adherence to the treatment model. Also joining us is Kate Appleman. She is the Senior Director and Clinical Practice of Professional Development with a major focus on improving programs that support Caron's clinical teams. Since 2013, Kate has been active in program development, supporting Caron's evidence-based clinical programs for executives, healthcare professionals, attorneys, and those with opioid addiction. Her areas of expertise include motivational interviewing, working with family systems impacted by addiction, relapse treatment and prevention, and men's addiction treatment and recovery. She is also a certified clinical supervisor and a certified advanced alcohol and drug counselor, and holds a CSAT and CMAT certifications. And I will now hand the presentation over to Kate and Kim to get us started. And thank you again for everyone joining us.
Martha, thank you so much. I'm really excited to be here with all of you today. And it's so great to see we have people from Canada and all up and down the East Coast, West Coast, Denver. Just really excited to be here with all of you. So I'll go ahead and get it started. Dr. Vey, I'm really excited to really hear her portion of the presentation. We're going to start the presentation really talking about the importance of treating mental health issues and substance use issues concurrently. If you were in the field 20, 30 years ago, there were times when we tried really hard to treat them in buckets, and have since really realized that just doesn't work for a lot of reasons. So we're going to talk about that. Dr. Vey is going to talk about DBT assumptions and principles, and also really talking about learning substance use specific DBT skills. And I'm going to talk about the relationship between DBT and motivational interviewing, both of which are evidence-based practices that many of us utilize because we know they work. And they're a part of best practices in our industry. So that's really what we're going to be covering today. If you want to advance the slide. So when we talk about treating mental health and substance use concurrently, if you advance the slide, we know that research shows three things. For many of us that have been in the field, we know these three things to be very true, and I'd be remiss not to talk about them openly before we get started. We know that common risk factors that contribute both to substance use disorders and other mental health disorders, that they're common. There are risk factors that are the same for both. When we look at the ACEs study, as far as adverse childhood experiences, if we think about trauma and stress-related factors, genetic predisposition comes for mental health and substance use disorders. So a lot of the risk factors are very common. We also know that as clinicians, we very much talk about which came first. So we know that mental health disorders can contribute to substance use disorders, and we know that substance use disorders can contribute to mental health disorders. And the phrase that we've been using for a long time is, which comes first, the chicken or the egg? And it's really important to make sure that we get the substances that are mood and mind altering off board so that we can see what's left from a mental health standpoint, acknowledging that many times substance use, despite the genetic predisposition, many times substance use is a way of trying to treat mental health disorders and vice versa. So when we look at research, we need to just understand that the underpinnings, these pieces are very much true. Change the slide. So we ask ourselves who's affected. I think that two things are important to talk about. One, mental health and substance use disorders are much more common than we'd like to believe. Over 7.5 million people really struggling, but also acknowledging that when we talk about the 20 million adults that struggle with substance use disorder, almost 38% of them also have mental illness. Now, I've spent a majority of my career working in inpatient where that percentage is much higher. I would say about 85% of the people that we see in inpatient treatment have both a mental health and substance use disorder. But when we talk about kind of the general public, over 38% of those 20 million that really struggle with substance use disorders also have mental health disorders. When we talk about mental illness, if you flip the coin, we really look at the fact that among the 42 million people that have mental illness, about 18% of them also have substance use disorder. So it's really a mistake in a lot of ways to try to treat one without the other. Actually, many of the treatments for one work for the other, which is really what we're going to talk about today. The second piece, if you advance the slide, is really talking about the fact that while substance use disorders and mental health issues are not uncommon, Treatment is also something that not everybody gets. So when we look at some statistics from 2018 from the National Institute of Health, 52% of people who identified as having a co-occurring disorder, over half of them never got help for it. So when we talk about symptoms like addiction and anxiety, depression, bipolar, over half of the people who needed the treatment didn't actually get it. And then we also look at the fact that 34% of people who were suffering from both mental health and substance use disorders, about 34% of them, they got mental health treatment, but not necessarily substance use treatment. Now, we've had people like that in our practices, right? Where we feel like we're trying to treat symptoms of anxiety and symptoms of depression, and we feel like we're spinning our wheels because there's this whole other substance use disorder piece that's over here that we're struggling to help them get into remission. About 9% received both mental health and substance use treatment concurrently. And about 4% only received substance use treatment. So when we look at the importance of treating both, we know from a research standpoint that it is important, and there's a lot of people that aren't necessarily getting it. So I'm really happy that we have over 600 people on this webinar to really talk about this today. If you can advance the slide. So this is these are some statistics from June 2020, really in the beginning of the pandemic. And there's a couple of pieces that are really glaring here. When we asked people during late June, about 40% of the US adults reported struggling with some sort of mental health or substance use disorder. Now, if we fast forward about 2 years, really looking at the aftermaths of some of these statistics is what now is really showing up in our offices, in our treatment centers. The one piece that I find really glaring about this information is about 11% of the people really seriously considered suicide. So if you had 10 people in your office building acknowledging that 1 out of 10 of them had seriously thought within the past 30 days of taking their own life. So in the midst of the pandemic, this is where we were from a mental health and a substance use standpoint. And again, putting it into context, 2 years later, where's the aftermath? If you want to advance the slide. So just a couple of other statistics to talk about the importance of really addressing both. There's some information in here about young adults, but also adult treatment when we look at co-occurring issues. 46% of the people that were surveyed according to SAMHSA really looked at having substance use and mental health issues. I found from a cultural standpoint, the rates were higher among those from multiracial communities and actually lower from Asian communities. So, and when we look at some of the statistics, they're actually holding pretty consistent over a course of time. If you advance to the next slide, this really talks about a study that was done between 2008 and 2014 of over 300,000 participants. The one piece that I want to talk about here is the fact that rates were relatively unchanged throughout the duration of the study. So if you look at some of the rates of co-occurring disorders today versus 2008 to 2014, they're pretty steady over a period of time. What we know is that dual disorders are prevalent. We know that not enough people are getting treatment for them, and we know a lot more people need treatment for them. So the question really is, when do we need help? We know that people need the help, and many of them aren't necessarily getting it despite the fact that they need it. So if you go to the next slide, I wanted to put this information in here because many times people don't know necessarily when to seek help. And by the time they do, it becomes more challenging. It may be too late. So this is something that I found really helpful within our field to really look at when do we know that help should be asked for? And what you'll find is because there's so many similarities in treatment and symptoms for addiction and mental health, we're in a position where a lot of the reasons to get help or the red flags that really come up that tell us that maybe we should pick up the phone. Maybe we should start seeking support outside of maybe our family system and start asking questions and asking for help are related to some of these pieces. Because in the end, if you continue to the next slide, we want to be in a position where we're really thriving. We can talk about the pandemic here. We can talk about changes in our society. We can talk about changes, leading towards a recession, difficulty in the job market. We can talk about a lot of pieces here. And overall, where are we surviving or struggling, or we find our clients or ourselves in crisis? So part of really looking at evidence-based approaches is to move people from either being in crisis or struggling and helping to move them through survival into thriving. And that's really what we're going to talk about a little bit today. And as we do this, if you advance to the next slide, we really think about some of the effective behavioral supports and behavioral health approaches that really help co-occurring mental disorders. Now, I could have had 16 slides on this, but when you really look at the evidence-based approaches that are proven effective to really work with mental health and substance use disorders, here are the main ones that we really talk about pretty frequently. And today we're going to talk a little bit more about DBT. So I'm going to turn it over to Kim to talk through DBT assumptions and principles.
Thanks, Kate. Okay, you can go on to the next slide. Okay, you can go to the next slide. So the one thing to note as we go through this is that the strategies of DBT SUD are very comparable and similar to standard DBT strategies and commitment. So a lot of it is going to have an overlap. So I just put this slide on to show sort of the functions of DBT and then the modes along with the case management component. The difference, I guess, or the addition with the SUD is the support meetings that are held along with a strong family network that is important for recovery. You can go to the next slide. So when I was looking at what to really highlight, because if any of you are remotely familiar with DBT, there's so much to highlight. So I thought that one thing that I really wanted to hone in on are the assumptions about clients as well as assumptions about therapists. So I'm going to talk a little bit now about the assumptions about clients, because this is a difficult population to treat. I think we all can agree that we have a lot of difficult clients that we can get frustrated and we can get burned out. And I have found that when you can go back to some of these assumptions, it helps to reduce the frustration and helps to reduce the burnout. And it provides us with that opportunity to meet the client where they're at without judgment. And so that first assumption is that clients are doing the best they can. Even when there are times when it doesn't feel like the client is trying, or it doesn't feel like they're progressing the way they should be progressing, right? I think as clinicians, we have desires and we want to see them progressing in a certain fashion. And when they don't, then that can create frustration. And so when we can fall back to this assumption that they're doing the best that they can. And then the next assumption is they want to improve. That this is very closely related to that first assumption, that if we work under the assumption that clients don't want to get better, we will remain frustrated and we will remain burned out. So we can come back to this assumption that clients actually do want to improve. We just have to help them figure out what is getting in the way of that progression. What is getting in the way, whether it's emotions, environment, lack of skill. So being able to identify what the barriers are, as opposed to falling back on they just don't want to get better, they're not trying hard enough. Which leads into that third assumption of clients need to do better, try harder, and be more motivated to change. This is a part of which we will talk a little bit about, sort of the dialectic in DBT of change, acceptance, and change. And so while we meet the client where they are, we still are pushing them to change. And this can be difficult because it's very easy to stay on one side of the pool with them. It's very easy to stay polarized in where they're at and not push them to change, because oftentimes pushing them to change creates the stress, right? And whether that the stress is uncomfortable for us as a clinician, or it's uncomfortable, and probably both and, it's uncomfortable to sit with the client in distress. And so recognizing that even though clients want to improve and they're doing the best they can, they still need to do better, try harder, and be more motivated. Clients may not have caused all their problems and they have to solve them anyway. This one helps get out of that space of it's not my fault. Absolutely, a lot of what our clients struggle with, they did not create. They did not cause all of their problems, and it's up to them to work to solve it. And it's up to us to help them move in the direction of solving those problems. The lives of our clients can be unbearable. This assumption to me is very powerful when it's hard to sit in a room with a client that is really struggling. And they may be, it's that hate you, don't leave me type behavior. They may be trying to push us away. And when we can fall back on and go back to this assumption that their lives that they're living are unbearable. And if we had to live the lives that they're living, we might have some of the same reactions interpersonally as they do. So recognizing this assumption can help us get unstuck emotionally and recognize that we can sit in the space that they're in, accepting where they're at and pushing them to change. Client must learn new behaviors in all contexts. This is where in session or in groups, clients may present one way, or with their significant others, they may present one way. However, it's our job to help them generalize that into other contexts where maybe there's emotional stimuli that aren't present in other situations. So it's helping them learn that they must learn these behaviors in all contexts, not just the context that it sort of works for them in. And that clients cannot fail in therapy. The word fail is going to come up a few times in the next assumption, in the assumptions about therapists also. And I challenge you all to look at this word from a non-judgmental lens. Fail does not need to be a judgment. It just simply means we're not reaching our goals. So it doesn't mean that they've failed in the judgment sense. It just means that they have not reached their goals and that clients cannot fail. It just means that maybe we did not apply the principles, or we did not apply the treatment, or it's not the right treatment, right? And so when we look at that assumption, it helps us not get polarized. And there is no absolute truth. You can go on to the next slide. Those are the assumptions about clients and the assumptions about therapists, because we are fallible. We all have either done or have made mistakes that our teammates have made and our clients. And so it's important for us to, in addition to the client assumptions, that we refer back to our assumptions about ourselves, that the most caring thing that we can do is help clients change in ways that bring them towards those goals. This goes back to one of that assumption about the client of it can be distressing. It can be distressing to push them towards those goals. But that's where some of the commitment strategies come in to help them see that we can accept where they're at and push them towards their goals. The most caring thing we can do is move them towards their goals and not allow them to stay stuck and stay comfortable in that uncomfortable space that they may be in. Clarity, precision, and compassion are the utmost importance. Being able to really have a clear picture of a clear case conceptualization, a clear understanding of the case of the client, which we're going to get into with the biosocial, of really understanding sort of the etiology of where some of their pathology and some of their behaviors may be coming from, really helps us to be more precise in the treatment that we're providing. And the therapeutic relationship is a real relationship. We are just as fallible as our clients are, and we are in this together with them. We're rowing the boat in the same direction. And so this is really important when we're asking clients to do things and change things that are really difficult to change, right? Like the change behaviors that have seemingly ineffectively worked for them. We're asking them to move away from that behavior. And so we have to, the relationship is key in outcomes when it comes to working in the DBT and with this population. Principles of behavior are universal, affecting DBT providers no less than clients. So we are just as susceptible to emotions. We are just as susceptible to becoming dysregulated possibly. So being able to use our team to recognize that we are not absolved from a lot of the behaviors that universally affect all of us. DBT providers can fail. That fail word again. And this is essentially saying that we can provide the treatment either and not in line with the way it should be provided, or we're providing the wrong treatment, that this isn't the treatment that the client needs. And so again, anytime you hear the word fail, really think of it in a non-judgmental, just not reaching goals. And then the treatment can fail even if DBT providers do not. Again, it can be it's just not the right treatment or not the right approaches. When we add DBT, I think DBT offers a big space to have other evidence-based practices be a part of it. So towards the end, Kate's going to talk about MI and how DBT alone may not be what the client needs. They may need other approaches. And so looking at what is the whole, again, going back to that clarity and precision, what does the client need? You can go on to the next slide. So looking at the principles of DBT, the biosocial theory, dialectics, validation and acceptance, and behavior change. So I want to talk about biosocial theory for a little bit. You can go on to the next slide. And the ultimate goal of DBT and the ultimate goal of even working within different evidence-based practices within DBT is helping our clients reach that life worth living goal, helping them reach that life that they want to live. That may look different for everyone, but it's helping them move in that direction. So I think one of Kate's earlier slides, she talks about sort of like the early understanding where some of this comes from in the predisposition of some of the mental illness, the mental health piece of it. So the biosocial theory really looks at that dialectic of the biology of sort of the client's temperament. Sort of like we all have an eye color, it's not good or bad, just different. And then the environment that the client grew up in. So when we have an emotionally vulnerable person, so biologically, they're just more vulnerable. So their eye color is more sensitive, so to speak. And they grew up in an invalidating environment. That's where then we see this problems with the ability to understand and label feelings and emotions, that inability or that deficit in coping skills, and that ability to modulate their emotions. You can go on to the next slide. So with the emotional vulnerability, we see, so as I'm talking through this, it could be helpful to like put a client in your mind and see how this sort of applies to them, because the emotional vulnerability, we look at a lot of clients coming in to treatment, you can look at it as if like have third degree burns, right? So if I have third degree burns on my arms, if you come near me, it's going to start to sting, right? You don't even have to touch me, and I might feel like it's starting to sting. So that's that high emotional sensitivity. So I'm going to be very reactive when you start to come near me because it's starting to sting, and I'm afraid you're going to touch me with third degree burns on my arms. And so that high emotional sensitivity, that high emotional reactivity, and then that slower return to baseline. So they stay elevated, staying highly emotional, highly reactive for a longer period of time. That's harder for them to come back down to their baseline. And go on to the next slide. So what we need to teach, and what we're teaching in DBT and with MI, is looking at labeling emotional experiences. If we cannot regulate an emotion, we don't know what it is, right? And so being able to understand, label emotional experiences, orienting attention when needed, increasing or decreasing that physical arousal, understanding the body sensations that are associated with emotions. All emotions have a body sensation associated with it. And, you know, when we're looking at emotions and cognitions, a lot of times it's the chicken or the egg scenario again. But when we can identify the body sensation, it helps us be more precise in the emotion that the client may be experiencing. decreasing that mood dependent behavior. So understanding, again, reorienting the attention, decreasing mood dependency. And that's where the structure of DBT also is helpful in that it prevents that mood dependent behavior in session because it's structured, it's targeted. So we're not just dealing with mood dependent behavior. We're dealing with more of the targets that are, again, the goal is to lead them in the direction of going towards that goal, their life worth living goal, the goal directed behavior. And then working to create an environment that supports emotion regulation, which is why the family network and that the community piece is so important. I'm going to the next slide. So with an invalidating environment, oftentimes what we see is there's this pervasive invalidation of the child's inner experience. It does not, I want to preface that this does not mean abuse. This does not mean neglect. This simply means the child's experience was not acknowledged. And that may be because the child's experience was out of proportion to the situation. So a lot of this can sort of fall into that crying over spilled milk, right? Like, there's nothing to be upset about. Why are you so upset? But that sensitivity, right? Like if I have 3rd-degree burns, why are you so upset? I didn't even touch you. I didn't even come near you, right? But that experience is invalidated. And then a lot of times those displays of emotions are ignored or punished. And so when they do show emotions, they either get ignored or they get punished for having an emotional reaction. Oversimplification of, okay, just go to your room and calm down and come out when you're calm, right? Just oversimplifying being able to regulate and modulate their emotions. And sometimes the environment's just right and help is provided. So, but typically when we're looking at the invalidating environment and the social component of it, the environment is missing that private experience that the client is experiencing. You can go on to the next slide. So consequences to that are our clients, we have an inability to accurately label internal experiences because we don't trust our experiences, because everybody's telling us we shouldn't feel that way, right? Like everybody's telling us it's not a big deal. There's no reason to feel that way. Why are you so upset? So over time, again, going back to that pervasiveness, right? Like this is a pervasive invalidation, not just a one-time thing or two, it happened once or twice. That pervasiveness of the pervasiveness of invalidating and then not being able to label those experiences or trust those experiences. So then there's that emotional escalation or that emotional inhibition. Depending on how the environment is responding, the escalation may be because they get attention when they get escalated, or the inhibition is I'm going to get punished if I have emotional, so I need to inhibit it. And sometimes we'll see perfectionism as a way to sort of control those emotional experiences and just becoming very perfectionistic in different areas. And then the oversimplistic inner passive problem solving. On to the next slide. And then, okay, so now looking at this central dialectic of DBT of acceptance and change, I want to go into the acceptance portion of this. You can move to the next slide, of balancing thoughts, emotions, and actions, which are the dialectical piece, right? Extremes are miserable on either end, right? A pendulum's always going to swing back to the middle if we allow it to. Sometimes it takes work to keep the pendulum pulled on one side or another. And so we want to find that synthesis that is in between those opposite positions. On the next slide. So validation is on that acceptance side of authenticating, expressing, finding that kernel of truth in an individual's experience. We don't validate the invalid. So not validating the behavior that's ineffective, but validating that experience. It must be really hard to have X, or I can imagine. And so it's just expressing that you get the other person's experience, or that you're finding that grain of truth. When it doesn't feel like there is, when we feel polarized, asking like, what are we missing, right? Like, what is that synthesis that seemingly could be in the middle of these two opposing two opposing positions. You can go to the next slide. So so there's 6 levels of validation. I'm not going to go through these for sake of time, but the 6 levels of validation really start at just staying awake. Hopefully the 660 some people here in level 1, or at least doing V1 of validation. And then the accurate reflection, when we're communicating, we're reflecting back, creating a hypothesis, helping them start to explore what they're experiencing. Next slide. Validating in terms of personal history. It makes sense that you're feeling this way because of X. That helps to separate the past from the current and doesn't make the current feel like the past, right? And so it makes sense that you're feeling this way. We're validating that they're experiencing something based off of something in the past or their biology. Normalizing, other people going through this may feel the same way. You're not alone in this, because we can also feel very polarized. And then V6 is just that, treating it valid, that not patronizing or condescending, just being radically genuine. Next slide. 2 types of validation: the verbal validation using 6 levels, those 6 levels, and then functional validation, nonverbal communication. So if the cameras were on, there'd be hopefully a lot of functional validation of just like facial expressions and body postures, and just that more like unspoken sort of validation. Go on to the next slide. Okay, so now I want to talk a little bit about the skills that have been added into distress tolerance as the SUD specific skills. So the goals of skills training are very similar to the goals of standard skills. We're looking to increase the motivation to reduce or stop use, and increasing awareness of the urges, increase the awareness of the vulnerabilities that increase our propensity to relapse, or what are the vulnerabilities that lead in that direction and lead away from our goals. On the next slide. You can go on to the next slide.
I'm sorry, I'm having a little trouble advancing.
So while she's moving on to the next slide, oftentimes, so like in the alliance that we have the DBT SUD portion of it, we bake in the SUD skills within the other modules, because all of the skills are going to be important, but these are the 7 specific SUD skills that have been added. And so we're working to eliminate active substance use, decrease the discomfort of that, so recognizing the vulnerability that comes with that, decreasing the urges, decreasing the options to use, the context for cues, right? Like that, recognizing that there is context, that what is leading more towards the relapse road as opposed to the life worth living road. And looking at the community reinforcement. You go on to the next slide. So staying off of drugs requires that clear mind action. And so this is a very similar as the 3 states of mind in standard DBT. The clear mind is where we want to be. The addict mind is those emotional benefits of using, whereas the clean mind is belief that I can handle this problem alone. I can drive by the liquor store. It's not a big deal. It's that the clean mind is still not necessarily understanding the potential for relapse, and that I can just use a little and it'll be okay. So the goal is to have clear mind, where the goal of substance use is the ultimate goal. It synthesizes these 2 addicts, the addict mind and the clean mind. Go on to the next slide. So I'm not going to go through all of this for sense of time, because you all will get this slideshow, but this really just highlights sort of the addict mind, that the impulsivity of the addict mind, the naive risk-taking of the clean mind. You can go on to the next slide. And then how we're moving towards that clear mind, where the safest place for us to be, that you're clean, but you remember that you can still remember your addict mind. So you radically accept relapse is not impossible, but you enjoy your successes while expecting cues and planning for when you're tempted. And go on next slide. So the 7 skills that have been added to in response to specific SUD. The dialectical abstinence, and this is that synthesis between dealing with addictive behaviors and the harm reduction. And so looking at in the cognitive piece of the harm reduction, where it's like some of the MI stuff is going to come in. The clear mind, the goal of being in clear mind. The community reinforcement, focusing on restructuring the environment so that it'll reinforce abstinence instead of addiction. Right? So how do we restructure the environment, which is that family network, the community network portion of this that is structured in a sense that is supporting abstinence as opposed to addiction. Burning bridges, looking at eliminating those connections to potential triggers for addictive behaviors, and then building new ones. And so looking at actively imagining, vividly, sort of imagining what does new connections look like, what that new environment looks like to move away from addiction into abstinence. Alternate rebellion. This is oftentimes addiction can be a form of rebellion, form of going against rules, as with other behaviors. Alternate rebellion is a way to have rebellious behavior that is not harmful to yourself or to others. And so this can be a really fun one to come to problem solve and to discuss with clients on, like, what can some alternate rebellion behaviors be that you still feel like you're rebellious, but you're not harming yourself and you're not harming others. That there's still that piece of, look at me, I'm rebelling against social norms, I'm rebelling against what maybe socially would be acceptable, but not in a dangerous or harmful way. And then adaptive denial, this goes to the sort of what we talked about earlier with the clean mind of adamantly convincing yourself that you don't want to engage in addictive behavior and that it's not possible for relapse. And so recognizing that relapse is possible and that there is a part of addiction is a part of you. And so learning how to sort of hold space for that while working towards abstinence. You can go on the next slide. So I'm going to now pass it over to Kate to talk about some of the MI and DBT core principles.
Kim, thank you. Thank you so much. It's interesting when I listen to you talk about the key assumptions and principles related to DBT, I'm reminded of times in teaching actually at Alvernia University, where one of the assignments that I used to give to students was to actually create Venn diagrams to talk about the overlap in evidence-based approaches. And as you talk about DBT, and I think about the overlap of MI, which we're going to talk about in a minute, but I also think about the overlap of cognitive behavioral therapy, that there's so much overlap between CBT and DBT. And that CBT is such a huge component of dialectic behavioral therapy, as well as motivational interviewing and mindfulness-based stress reduction, when you think of some of those pieces. So I want to just talk about, for a few minutes, just some similarities in the core principles between DBT and motivational interviewing, and actually 3 different key aspects that make DBT and MI similar in a lot of ways. So core principles, as Kim had talked about, for DBT, the biosocial model, or biosocial theory, acceptance and change, and dialects. With motivational interviewing, we talk a lot about empathy being the cornerstone of that approach, the importance of really rolling with resistance, which there's so many aspects of DBT that do the same thing. And as Kim had talked about before, she used the example of learning new behaviors in all different contexts, so that who you are in your relationship but also who you are and the way that you present in group and in individual, to really make sure that those all match. And in motivational interviewing, we talk about really pointing out the discrepancies between how you are and the choices you make, and the discrepancies between that and getting to where you want to go and what really your goals are. So 3 pieces that I want to talk about very quickly, if you can go to the next slide. So talking about the relationship between DBT and motivational interviewing, the first piece is that both really focus on strengths in a lot of similar ways. So when we have clients that come in and are really struggling to emotionally regulate, maybe struggling with self-worth, with substance use, really feeling uncomfortable in their own skin, us as practitioners really focusing on strengths, I think is a good place to start. And both with DBT and MI, it's the place to start and it's the place we continue to be. It is all strengths focused. So with motivational interviewing, we really hinge on the importance of setting goals to achieve a better quality of life is usually the words that we use. Very similar to building a life worth living. So many of the ways that we look at it can become very similar. With motivational interviewing, there's this belief that everyone is motivated for something. It's just a matter of what is that something that they are motivated for. And we very much try to lean into a strengths perspective to help them understand that whatever their motivation is and wherever it is that they want to go, they have the strength and capacity of getting there. It's a matter of how do we work together to get there. A lot of shifting in focus where somebody may be problem focused instead of solution focused. We talk about really acknowledging in motivational interviewing where I am, where I want to get to, and steps to actually get there. Pointing out the discrepancies between where you want to go and how your behavior is or isn't supporting that. So a lot of focus on strengths perspective. The second piece that when we talk about the relationship between DBT and MI, if you go to the next slide, is really focusing on the fact that they're both very relational in nature. Dr. Vey talked a lot about the importance of having a validating environment when it comes to the use of DBT. With MI, again, we center our focus on empathy, not authority. The truth is people are the authority of their own lives. And we want to focus on empathizing with really where they are. Because the truth is judgment, as we had talked about kind of the assumptions and the lenses related to practitioners, we know that judgment doesn't get us very far, and it also doesn't get our clients very far. So really making sure that we're hinging on empathy, or the ability to put ourselves in their shoes, acknowledging that they're doing the best they can and they can do better. We talk about considering relational motivation. So if relationship is, if it's relational in nature, relationships can be incredibly motivating for people. Really asking them if they're looking at their quality of life, is the quality of their relationships what they want it to be? And if it's not, maybe those are some of the motivations that they have to be able to change. I'm going to continue on. Let's go to the next slide. Just for the sake of time. The last piece I want to talk about is when we talk about similarities, is both DBT and MI really focus on autonomy of the individual, and also looking at the individual or the client. They're the expert. They're the ones that are, while we may be providing them with skills, they're the ones that are really utilizing them. With DBT, we're obviously very much skills focused, and helping clients even create their own skills when appropriate. One of the things that we were talking about before the webinar had started was it's really difficult to answer some of the questions because the answer is it depends, right? It depends on the client individually, where they are, what they need, what skills they're responding well to determine what skills to continue to put in front of them, and looking at our approach. With motivational interviewing, we do look at the person as the expert and also really focus on rolling with resistance. Dr. Bay had talked about before the concept of failure, right? She had talked about really focusing on if the treatment isn't working, is it the appropriate treatment, right? So I think that there's a lot of commonalities between that concept and really rolling with resistance and what that looks like. They have the right to make their own decisions. When we look at a better quality of life or a life worth living, both DBT and MI really shine a light on acknowledging if their behaviors and their choices are getting them closer to or further away from the life that they want to live and the quality of life that they want to have. So I just wanted to highlight those three similarities. On the next slide, if we really look at integrating motivational interviewing in DBT, in a lot of ways, motivational interviewing with clients that may be struggling with making changes, sometimes MI is a good platform to help motivate someone to become more willing to utilize DBT in a consistent manner. So when I look at it, again, Venn diagram, there's a lot of similarities between the two. And there are times when MI can really set the stage for someone to be more compliant, more adherent, probably, to a full DBT course. So incorporating MI earlier in treatment can actually reduce the ambivalence and help with readiness to change. We can then incorporate DBT while maintaining the MI spirit. So when we talk about that empathy of really understanding where they are, that spirit is very similar to spirits connected to dialectic behavioral therapy. DBT at that point can really then just focus on his purpose. When we talk about reduction of behaviors that just aren't working, continuing to increase skillful behaviors and building that life worth living. Sometimes motivational interviewing to get people to the point where they're motivated to want to change can set up DBT to be even more effective. So that's a lot. I know that we're just about out of time and wanted to hold some space for questions. So I'm going to end there. You'll find the next two slides is a bibliography that if you want more information, there's a lot of information there for you if you want to dig a little bit deeper.
Thank you so much, Kate and Kim. That was a great presentation. We have time for a couple of questions. And just as a reminder, any questions that we don't get to, we will follow up with you after the presentation directly. So for our first question, is the initial evaluation about mental health issues done then again after the person has detoxed at least 45 to 60 days of zero alcohol and or substances?
Yeah, I can actually start that question. I think when it comes to evaluation, the answer is yes, yes, and yes. I think evaluation is incredibly important upfront, even when substances are on board. I also think that when we look at mental health and acuity, when substances are put down and someone goes through initial acute withdrawal, even protracted withdrawal, about 45 to 60 days out, the picture can look very, very different. So if you have somebody who's using alcohol and they present with a significant amount of depressive symptoms, it makes sense to a certain degree because they're drinking a depressant, right? If we have people that have different substances on board and their baseline anxiety is pretty high, they may look very, very different 60 days out. So I think it's really important to assess thoroughly up front, but then continue to assess along the way because the needs just may change. That's probably how I would answer that question.
Thanks, Kate. Next question. Do you have any tips to go beyond DBT homework or worksheets for scenarios when brief intervention is needed?
I can take that question. So yes, and this is another, it depends on exactly what that looks like, depending on where the client is. However, the thing to keep in mind is at all cost assessment and looking at determining function of the behavior. Because if we're looking at sort of the biggest bang for your buck, so to speak, if we can identify what the function of behavior is, then we can identify what skills are needed or what skills would be most effective. And so really looking at what are those controlling variables, what are those vulnerabilities that are leading to the problematic behavior or leading to the dysregulation. And when we can identify the function, then we can identify an effective problem-solving intervention that would be in line with the function. And so it would help to target what is maintaining that behavior. So I would say identifying the function of the behavior and really honing in on assessment.
Awesome. Thanks, Kim. And we had a question come in from the chat about resistance. What does it mean to roll with resistance?
I'll start with that, and then Kim, maybe
Okay.
you want to piggyback. So when we talk about rolling with resistance from a motivational interviewing standpoint, it's really getting away from, client wants to keep drinking and we tell them drinking's really bad for you. Client wants to make changes in the relationship and says, my wife's the problem. We say, well, no, you're the problem. That kind of language creates this dynamic that in the relationship, it becomes almost like an us against them. It's really difficult to feel validated, to feel understood, to want to open up more, to reduce resistance, to reduce barriers. And then when we make choices like that in the midst of a therapeutic setting, people look pretty defensive because they feel like they need to protect themselves in your office. So when we talk about rolling with resistance, it's really hinging back on what their goals are, even if you don't necessarily agree with their goals, really hinging back on what their goals are and how to support them in getting to where they want to go. Whether we agree with them or not, we are able to be in a position where if we have people that are doing things that are harming themselves, that are harming other people, we're of course going to lean in with empathy and express care and concern and be really open about those things. But the rolling with resistance is, for example, if I have somebody who's not willing to stop drinking altogether, but they're willing to reduce the amount that they drink, I'm willing to meet them there and as a means to build relationship and hopefully even move them a little bit further, that they may get to the point where they realize, you know what, my life is actually better not drinking. And they come to that solution or that conclusion, and it's not me coming to it. Those are some of the examples that come to mind for me. Kim, do you want to add to that?
Yeah, I can just add that also looking at oftentimes resistance and lack of commitment can get conflated. And so if we look at resistance from that space of what is getting in the way and what is making them resistant, we're asking them to do something really hard, then it can also move us away from they're just not committed, right? Like if I really want to get in shape, but I don't go to the gym today, it doesn't mean I no longer want to get in shape. It means something got in the way of me going to the gym. And so I think it's looking at it from a less polarized definition, so to speak, and that it's recognizing that we're asking them to do really difficult things. And we may, like Kate said, our goals for them may be different than their goals. So it's keeping that in mind also, but recognizing that resistance is different than not being committed. And so when we don't assess for the resistance, then oftentimes they get plugged into that bucket of they just don't want to change. And so rolling with that helps to move towards commitment.
Awesome. Thank you again, Kim and Kate, for your awesome presentation, and also to all of our attendees for joining us today. As a reminder, this presentation is eligible for 1 continuing education credit. So watch your email for a link from cego.com to complete your eval. And we will send out the slides to everyone and a recording of the webinar in about 14 days to the email that you registered with. I would love to update you guys as well about an exciting new opening of Caron, Florida's new medical center called the Keel Center. This amazing 100,000 square foot building offers an older adult program, an expanded residential Ocean Drive program, detox, and also neuropsychological services. I'd also like to share that Caron, Pennsylvania is in network with a number of insurance providers you see here. We continue to expand our access to care, so please don't hesitate to reach out to determine eligibility of benefits. And please see the contact information for Caron Atlanta and Peachtree Comprehensive Health on this slide. In the meantime, please reach out to your local regional resource director anytime for additional information, resources in your area, or any questions regarding an admission to any of Caron's programs. Thanks again to everyone for joining us, and we hope everyone has a great afternoon.
Thank you.
Thanks.